Moving along into our metastatic space, where we have EV Pembro, incredible results, and based on EV302, we have adapted that in our frontline setting. Any role of utilizing chemo immunotherapy instead of EV Pembro or giving chemo followed by avelumab maintenance therapy?
Yeah, that's the $1 million question, right? So yeah, we have been using chemotherapy, platinum-based or carboplatin-based, and then switching to maintenance avelumab when this was approved in 2020, 2021. But now with the advent of EV Pembro, that is in unselected patients, including fit and unfit, with this benefit in survival, in progression-free survival, the responses are seen in patients independent of being PD-L1 positive, independent on even we see responses in liver mets, so the same benefit or the magnitude of benefit is seen in patients with liver mets, whatever. So even in performance status, although limited patients with ECOG2 were included in the trial, we see that this is really a regimen that is widely used. I could say that nowadays maybe 85% of patients are receiving enfortumab vedotin pembrolizumab. There are patients that cannot receive because of ongoing immune suppressive treatment or they have immune-related diseases. Patients with neuropathy in the very beginning cannot receive enfortumab vedotin. Patients with, like, let's say, and there are no definition of who is EV Pembro ineligible. So it's very, very there.
Right.
We're working on that. Patients with skin diseases that cannot receive EV because EV is targeting Nectin-4 that is expressed in the skin. Then you have all these limitations, but if not, EV Pembro is really a good regimen, mainly in patients, and these are now under discussion, mainly in patients with transitional histologies. There is data emerging that is, those are the ones that are benefiting the most. But patients having squamous histologies, adenocarcinoma histologies, mixed variants, more than 50% likely are not responding the same, and maybe we need to look for other options. And this is where sometimes we are discussing to use cis-gem nivolumab, for example, because this cis-gem nivolumab is multi-purpose, giving chemotherapy and immunotherapy. Yes. Some people say maybe for squamous histologies or high components of squamous, this is a better regimen. For this trial, cis-gem nivolumab at ASCO, it was reported that patients with low volume lymph node disease, these exciting, extraordinary good responses, but then the same is seen also for EV Pembro. So it's not the best, but selected patients might respond better. Maybe we need to look for more for platinum predictive factors that still we don't have, despite we have some. And then for the last regimen, that is cis-gem or carbogem followed by maintenance avelumab, if we are able to identify again patients who are going to respond to cisplatinum, maybe it's a good strategy, starting with chemotherapy. But here we are excluding those that are progressing. And this regimen is still being used in countries or areas of the world. We need to think that the cost of EV Pembro is high, and there are areas that don't have access to EV Pembro, for example, and meaning that using the other two regimens, it's an option because they have a proven survival benefit. For nivolumab cis-gem, we need to highlight that this trial is done only in patients who are fit for platinum. It didn't include carbo-eligible patients. It's only cis-gem nivolumab, meaning it's a small selection of patients. That is like the selection of patients that is being done in the avelumab, in the switch maintenance trial, the Javelin trial. So where only the responders receive immunotherapy, and those are the ones that were analyzed in the trial, showing that the length of survival, if you count from starting the chemotherapy followed by the maintenance avelumab, the survival is pretty large. It's close to the one seen with EV Pembro. So we need more criteria for specifically select, but nowadays, the easy to use and also quite well tolerated, the nausea, vomiting is not seen. You need to pay attention on a close follow-up, on the neuropathy and skin side effects, but EV Pembro is presently the most widely used regimen.
And then EV302 doubled the overall survival. It's not just PFS. We're seeing doubling of overall survival here. A big question ends up being, yes, majority get exposed to EV Pembro, but then second line and beyond, we have erdafitinib, TDXD. Joaquim, can you touch on the second line and beyond, and importantly, when are you looking for NGS?
Yeah, so this second line is, again, we have, as you mentioned, this doubling survival. And it was said that the EV302, the comparison arm didn't include maintenance avelumab because this was modified in the end. So there are nuances. So doubling the survival is what makes people just to switch to the EV Pembro. But then after that, what to do next? If you have not been using the platinum, one of the first things that come to our minds is, well, let's use platinum here in the second line, because we know that platinum gemcitabine that has been used for 25 years is useful. In general, that's the type of regimen that is more frequently used. But the question comes whenever you have a patient with a tumor that has targetable genomic alterations, like EGFR or HER2 IHC3+. And then the question is what to do with these patients. We have no randomized trials here. People tend to use platinum-based regimen. I can tell you that we're going to present that at next ASCO. In patients with targetable genomic alterations, the response rate, because you're selecting patients, is higher or similar to platinum gemcitabine. We need more data. We need to know the duration of response and what to do in a patient in second line that has an FGFR mutation. Do you need to give platinum-based and then erdafitinib? Or it's better to start with erdafitinib and then give the platinum? We don't know presently. We have a drug that we know that is in this setting, in fact, in third line setting, a drug that we were thinking to have a new option, a new ADC, that is the sacituzumab govitecan against TROP2, and using a different payload that is not the monomethyl auristatin, that is the payload of, meaning it's not inducing neuropathy, and that this sacituzumab govitecan, we had data of responses in patients that fail EV. Unfortunately, the TROPiC-4 trial that did randomize in this third-line setting sacituzumab govitecan versus standard chemotherapy was negative, likely because of early death. Still, we believe that SG, now withdrawn by the company, could be an option in bladder cancer because we have limited options. The second line is a new space that we need trials, and in fact, trials are being designed. But as mentioned, platinum-based, cisplatinum, carboplatinum, depending on the residual neuropathy that you see with EV Pembro, or the targeted therapies, the trastuzumab deruxtecan and HER2 in patients IHC3+ only, unfortunately. Yeah. And then obviously the fitinib that we know is 40% of responses in patients with FGFR genomic alterations, mutations, or translocations.
Particular space is getting complicated. It is important to keep sequencing in mind, but as you stated, keeping in mind skin toxicity, peripheral neuropathy, alopecia, hyperglycemia. For TDXD, alopecia is certainly a concern, but not forgetting ILD, which is related to death here. With regards to erdafitinib, any key side effects to keep in mind, Joaquim?
Well, usually these patients are being seen by our ophthalmologist first, and a close follow-up is needed. So we see that there is a lot of side effects in the skin, in the nails. Patients can lose the nails. So it's a drug that requires you need to look for hyperphosphatemia. That is like a biomarker of efficacy, and sometimes you need to dose reduce. I can tell you, my patients are not on the 8 milligrams that is recommended or 9 milligrams all the times. Sometimes you need to go down to the dose you need to be a bit knowledgeable, have more experience in managing erdafitinib. And we know the duration of response is 5 months in the second line, right? And then say, well, is it worth us to go through these side effects for this period of time? Maybe we can start the platinum, but still we don't know what's the best. And then, as you mentioned, the trastuzumab deruxtecan, the ILD that is described to be in 6% of the patients, this is something that sometimes need to the requirement of treatment discontinuation. This is more frequently seen in patients with impaired renal function. Patients with poor creatinine clearance, close to 30, it's risky to give, you need to dose reduce that based on the recommendations, and the incidence of pneumonitis induced by Enhertu is increased.